Welcome everybody to this webinar, a part of the basic webinar series of EURO-NMD. We organize these webinars in collaboration with European Reference Network for Rare Neurological Disorders and the European Academy of Neurology. These sessions are basic and clinical. Basic not in the sense of basic science, but in the sense of medical basic clinical signs and syndromes and things like that. Federica Montagnese works currently in the Friedrich-Baur Institute in Munich, and she trained there, if I understand it correctly, and she has a great luck to be in a very good center for neuromuscular disorders. And she has a spiny mission of talking about cramps and hyperexcitability. I'm calling it a bit spiky because, in fact, most of the patients we see that complain of that do not have, in fact, disease. But it's very important to detect the ones that have, and Federica is going to tell us how to do it. Thank you, Federica, for accepting to do this webinar, and the floor is all yours.
Thank you very much for the nice introduction, and thank you also for the invitation to hold this webinar. These are just quickly my disclosures, which are not relevant for the topic today. And I thought that before diving into pathology, it would be helpful to remind ourselves some important anatomical and physiological informations that are related to neuromuscular excitability. And then I will show you the semiology of some of the most important clinical features of muscle hyperexcitability or nerve hyperexcitability. We will discuss the main diagnostic pathway and differential diagnosis, and then some therapeutic options. So if we come back to the main characteristics of skeletal muscle, the muscular tissue has three main characteristics, which are excitability, so basically the ability to respond to stimuli, for example, electrical stimuli as in nerve impulses, contractility, so the ability to shorten in length and then relax, and then extensibility, so the ability to stretch when pulled. In particular, alteration of these first two mechanisms, so excitability and contractility, are responsible for most of the muscle hyperexcitability symptoms and syndromes. Therefore, we will quickly see the electrical, the excitation contraction coupling, where we know that the nerve impulse reaches the muscular membrane, the sarcolemma, at the motor end plate. Thanks to the coordinated activation of specific ion channels, we will have the generation of an action potential, which will propagate along the sarcolemma and across the myofibrils, thanks to the T tubules. The dihydropyridine receptor will then be able to detect these changes of the membrane potential and activate the ryanodine receptor, which will then fast release a high amount of calcium, which is stored in the sarcoplasmic reticulum. And this quick increase of the sarcoplasmatic calcium concentration will allow the change of conformation in troponin the binding sites for myosin will be exposed, so that we will have the formation of bridges between myosin and actin. We will then need ATP to break again these bridges and to create new bridges, and at the end of contraction we will have the reuptake of the calcium in the sarcoplasmic reticulum with a coordinated function of different proteins, and mainly these calcium ATP pump, also known as SERCA. So we can have this function at multiple levels of these mechanisms. We have the group of ion channel disorders, which is responsible for myotonic syndromes. We can have some dysfunction of the interaction between the dihydropyridine receptor and the ryanodine receptor, with alteration then in the mechanism of calcium release. We can have an impairment of ATP production or too low levels of ATP, which impairs the breaking of these cross bridges. Or we can also have impairment of this reuptake of calcium in the sarcoplasmic reticulum, so that too high calcium concentration will keep our muscle stiff and contracted. So that we can summarize the clinical features of muscle hyperexcitability into these main signs. Myotonia, with the typical electrical counterpart of myotonic runs, quite pathognomonic for myotonic syndromes. We have the different clinical features of rippling muscle disease, as rippling muscle, percussion-induced rapid contraction, percussion-induced muscle mounding, or myoedema. We can have contractures, which are mostly related to metabolic myopathies, or muscle stiffness that we see in Brody disease. And we can see that with the exception of myotonia, all these other forms of muscle hyperexcitability are silent on EMG. So we can start with myotonia, which is defined as an impaired muscle relaxation after activation, after muscle contraction, and usually it is a delayed relaxation that can be action-induced, as we see in grip myotonia, where patients have delayed relaxation after making a fist or holding a hand, shaking a hand. We can have percussion myotonia, which we can see here when we make a percussion of the tenor eminence. We can have some generalized form of myotonia, mainly affecting also the lower limb, with which can be detected in the 14 steps test, so which can be highlighted with repetitive climbing of stairs. We have some more specific involvement of the facial muscle, as we most commonly see in natrium channel-associated myotonias, as we see in this patient with this tongue myotonia, or in this other patient with the typical lead leg phenomenon. So if a patient looks up for some seconds and then really quickly looks down, then we will see that the eyelid will not follow as fast the pupils, and then we will have this lag. The clinical myotonia has a classical electrical counterpart, the myotonic runs, which are sustained rhythmic discharges of single muscle fibers, and they have this typical waxing and waning in amplitude and frequency, even though quite often we also see incomplete myotonic runs, mostly with only waxing or only waning progression. And maybe we can hear also these myotonic discharges on EMG. I must apologize if the sound is a bit too low. So this sound is often described as that of a dive bomber, or probably more easily of that of the acceleration and deceleration of a motorcycle. And we need to distinguish these typical myotonic runs from pseudo-myotonic runs or high-frequency discharges, where we have, differently from classical myotonic runs, a sudden onset and sudden interruption of these discharge without major differences in amplitude and frequency. And we can see these kind of discharges in many other neuromuscular diseases, as for example in Pompe disease, other glycogen storage diseases, and really often also in necrotizing myopathies. When we see the myotonia clinically and we hear the typical myotonic runs, the differential diagnosis is quite narrow. We should think of myotonic syndromes, which are muscle channelopathies. We can distinguish primary channelopathy if the genetic defect directly involve the ion channel gene, and we can then in this category account the non-dystrophic myotonia caused by mutation in the natrium or chloride channel genes. Or we can have also secondary channelopathies, as we see in myotonic dystrophy, where the genetic deficit is not primarily involving ion channel gene, but the mis-splicing of targeting mRNAs, as for example CN1, will cause the production of these functional isoforms of this protein. From a pathophysiological point of view, the main determinants for the generation of myotonia are for the dysfunction of these ion channels, especially sodium and chloride, which will either increase the sensibility of the muscle membrane to depolarization or reduce the efficacy of repolarization and hyperpolarization, so that we will have these repetitive generation of action potentials and repetitive discharges related to these elevated muscle excitability of the muscle membrane. From a pragmatical point of view, we should be able to distinguish clinically patients with dystrophic from non-dystrophic myotonias. As regards myotonic dystrophy, the typical features are the autosomal dominant inheritance with prominent anticipation for myotonic dystrophy type 1, the presence of additional muscular symptoms and signs which can be much more prominent than myotonia, as for example muscle wasting, muscle weakness, involving more consistently the facial muscles and more distal muscles in DM1, whereas the proximal and axial muscles are more involved in myotonic dystrophy type 2. Another important aspect suggesting a dystrophic myotonia is the prominent extramuscular involvement. So the involvement, for example, of the endocrine system with diabetes, thyroid dysfunction, cataract, cognitive impairment, heart involvement, and then the slow progression during the years. On the other hand, patients with non-dystrophic myotonia may have autosomal dominant or autosomal recessive inheritance. They are usually pure myotonic syndromes, so we really have these myotonia as a most prominent symptom, often associated with muscular hypertrophy and these athletic aspect. In some cases, we could have also weakness or episodic weakness, but there is a lack of significant progression and therefore mostly a much better prognosis. Once we have made clinically this distinction, we can then ask our geneticist to perform the correct test, which will be probably a multi-gene panel for a non-dystrophic myotonia and a serum blot analysis for the dystrophic myotonia, as we need to remember these are repeat expansion diseases which could not be detected by normal multi-gene panel analysis. This symptom, myotonia, is treatable. We have many anti-myotonic medications that we can suggest to our patients. In our everyday practice, we mostly consider mexiletine and lamotrigine as first choice medications, both with good efficacy and a bit different side effects profile that needs to be considered when we opt for one medication or another. Another important aspect in the choice of the first medication is, of course, the approval of a medication. So at the moment, the only approved anti-myotonic treatment is mexiletine, whereas all other medications are actually off-label. And then we have some also new treatments that could be considered mostly in some refractory cases. We can now switch to another form of muscle hyperexcitability. We know that many people usually may want to share many aspects of their life through social media, and in some cases they also share some symptoms in order to get useful hints from their followers, from their community. And this is the case of this guy which is asking his follower what is this symptom he is presenting. So we see these typical undulating movements of the muscle under the skin, activated, triggered by muscle stretching. And we see after a while the first comments popping up. Some of them are, of course, not very helpful, so I don't know, but it's quite cool. Some other can be scary. Some people suggest, for example, an ALS diagnosis, but then slowly also some useful comments come in. So one first comment is that Joe Linder has that, which is a German wrestler who became famous due to these movements of his pectoral muscles. And then the most useful comment also came in. So it's a genetic mutation. Some people have it and some don't. It's called alien gains. This term was actually quite new to me, but it seems to be well spread, quite common in the bodybuilder community. So we are talking about rippling muscle disease, which is mainly characterized by these three clinical symptoms, clinical signs. We have here the typical rippling of muscle, which is also described as a HARP phenomenon, also induced by stretching or a slight percussion of the muscle. We then have the percussion-induced rapid contraction, which is difficult to differentiate clinically from percussion-induced myotonia. We then have the percussion-induced muscle mounding or myoedemia, which is this focal tonic contraction of a segment of the muscle, as we see in this video, which is seen in rippling muscle disease, but also in other conditions, as for example in hypothyroidism. The cause of rippling muscle disease is a dysfunction of caveolae, so it's a caveolinopathy. The caveolae are present in many tissues of our body and also, of course, in muscular tissue. And caveolae are these flask-shaped invagination of the plasma membrane that plays many roles within the muscle. There are different isoforms, and this caveolin 3 isoform is the one present in skeletal muscle. And another important protein interacting with caveolin 3 and contributing to the formation of these caveolae are the family of the caveins, especially caveolin 1 to 4. So among the many different functions of caveolin 3, I have highlighted those that are more relevant for muscle diseases. In particular, caveolae can work as a reservoir of muscle membrane that can break open in response to stretching. So this is this wave we have seen basically on rippling muscle. They contribute to the organization of the T-tubules and regulate also the intracellular calcium concentration by modulating the activity of the ryanodine receptor. They also contribute to the maintenance of the resting potential by interacting with some potassium channels. They contribute also to the integrity of the neuromuscular membrane, interacting with the dystrophin glycoprotein complex. And they also play a role in the neuromuscular junction, in particular in the assembly of the acetylcholine receptors. So that we can now better understand the several phenotypes which are associated to caveolin-3 mutation. In addition to rippling muscle disease, we can have some limb girdle muscular dystrophy, the LGMD, formerly known as classified as 1C. We can have some milder forms with asymptomatic hypercemia or pseudometabolic with exercise intolerance, myalgia, and rhabdomyolysis. We can have some rare forms with distal myopathy, or some diseases with isolated cardiac involvement. And in some patients, we do not find a mutation in the caveolin-3 gene because they may show a mutation in CAVIN1 gene, which causes basically a secondary deficiency of caveolin-3. And there is this typical association of some rippling features with lipodystrophy and glucose intolerance. We also have some acquired form of rippling muscle, which are long known. The first cases have been described, for example, in association with myasthenia or with thymoma, and there were some hints that were pointing toward an immune-mediated genesis, as for example, the lacking of an association, of course, with a genetic mutation, and the good response in some cases to immune therapies. And only recently, the antibodies, which seem to be causative of these acquired rippling muscle disease, have been discovered by the group of Margherita Milone, and these are known as CAVIN4 IgG, which can be assessed in patients with suspected acquired rippling muscle disease. Another syndrome characterized by muscle hyperexcitability is Brody disease, which is extremely rare, autosomal recessively inherited, and the identification of the causative gene mutation was made possible also by the study of this phenomenon of pseudomyotonia in animals. So the mechanism is here a deficit of the calcium reuptake into the sarcoplasmic reticulum caused by a deficiency of this ATP calcium pump, which is mainly expressed in type 2 fibers. So we see here the typical features of Brody disease in this specific breed of cattle, these Romagnola cattle, and we see that after sudden movement, sudden exercise, these animals experience a sudden stiffness of the muscles, which is mediated by these deficits of calcium reuptake. In humans, the symptoms begins already in the childhood, mainly in phasic exercise. And in addition to the stiffness, which is usually not as prominent as in this video, we see myalgia, contractures, and mild weakness, and we have some cases of malignant hyperthermia related to general anesthesia. In EMG, we will not have any discharges, so it's silent contractures. And if we suspect this disease, we can analyze the ATP2A1 gene, and if we find some variants of uncertain significance, we can also prove their pathogenicity in muscle with immunohistochemistry or immunoblotting tests to determine the activity and expression of the SERCA protein. We also have other hereditary myopathies caused by defects in these mechanisms of regulation of the sarcoplasmatic calcium, so which are grouped into the calcium-related myopathies. In these cases, patients may experience myalgia, cramps, and contractures, but often prominent muscle weakness is their major complaint. Finally, we also need to account as a muscle hyperexcitability sign and symptom the muscle contractures, which can sometimes be difficult to differentiate with muscle cramps. They usually last longer than cramps and cannot be broken or alleviated by stretching. On the contrary, stretching should be avoided in order to prevent additional muscle damage, in particular in patients with metabolic myopathy, as for example McArdle. And of muscle contracture in this case is an energetic deficit, so the muscle is not able to produce enough ATP to break the cross bridges between actin and myosin, so that we have this contracture which is electrical silent on EMG. And this is a similar mechanism that happens after death, so with rigor mortis. We have now completed, in a way, the features of muscle hyperexcitability related to post-synaptic dysfunction. We also have a series of presynaptic alterations that will cause involuntary muscle activity, which can originate in the lower motor neuron cell body, in the motor neuron axon and its more distal terminals, or in the presynaptic voltage-gated potassium channels. So the classical neurogenic clinical features, so therefore of presynaptic origins, are cramps, fasciculations, myochemia, and also some muscle spasms, as we see in tetany, even though the term spasm should be better used to indicate involuntary muscle contraction of central origin, as we see, for example, in spasticity and in multiple sclerosis. And we have, of course, many different neurogenic neuromuscular diseases which are associated, which can be associated with these symptoms, but these can also be idiopathic or benign symptoms. We can start with muscle cramps. I think this is one of the most common complaints in the neuromuscular outpatient clinic. There are some estimates with an incidence of about 37% in the general population, with occurrence increasing with age. And I think almost everybody has experienced cramps during intense exercise, as we see, for example, in this tennis match, where this tennis player is experiencing really intense bilateral cramping of his thighs. The classical features of muscle cramps are the sudden onset. They are very painful. They are caused by supramaximal contraction of the muscle. They are transient and can be alleviated by stretching of the muscle. And in many cases, patients, especially after intense cramp, may experience post-cramping pain, probably related to local injury caused by hypoxic metabolic mechanisms within the muscle. If we perform an EMG during the cramp, we will see, differently from a muscle contracture, a very dense interference pattern with often gradual increase of the number of the motor units involved and the increase of the firing rate, followed by a slow decrease. And then in the phases immediately preceding or succeeding muscle cramp, we can have other forms of EMG activity as fasciculations, potentials, or high-frequency discharges. The origin of muscle cramps is still debated. In most of the cases, the experiments point toward peripheral neurogenic origin, so located in the motor nerve axon, especially in the distal terminals. But there are also some aspects which suggest spinal cord modulation of the cramping, as for example the modulating role of the activation of antagonist muscles, or the change in H reflex after cramping. Clinically, we can basically classify cramps into three main categories. We have the common physiological cramps that are a physiological response of muscle to extraordinary situation like intense exercise, or severe electrolytic disbalances. They involve mainly more distal muscle. They are quite predicting to specific situation and to specific phenomenology. They are benign and non-progressive. We then have some other forms of cramps that we define as idiopathic, because they occur a bit more frequently than common physiological cramps, as we see in nocturnal cramps, for example, or in benign cramp fasciculation syndrome. These are also some benign non-progressive conditions, but cramps can also be symptoms and alarm sign of other neuromuscular diseases, that need to be considered. So the non-neurological causes of cramps, mostly common or idiopathic cramps, are several, encompassing electrolyte disturbances, some medications, pregnancy, endocrine dysfunctions, hepatic or renal alterations, dysfunctions. And then we have many causes of neuromuscular origin, as in motor neuron diseases, peripheral neuropathies, cramps, fasciculation syndrome, plexopathies, radiculopathies, even myopathies. In order to approach muscle cramp, essential is the collection of detailed medical history, so that this will probably allow us first a differentiation between physiologic, idiopathic, and symptomatic cramps. So investigating, for example, the frequency of the cramps, which muscles are involved, if some new concomitant medications may be responsible for the cramps, if there are some triggers that consistently causes the cramps or alleviate the cramps. In the examination, we should look for red flags or for symptoms or signs that that are indicative of another neuromuscular disease. We can perform different laboratory tests, mainly to exclude the non-neurological causes, which usually are not very informative in everyday practice. And if we suspect the presence of a neuromuscular disease, the EMG and ENG will then guide the future diagnostic steps. The therapy of muscle cramps is quite challenging, since often it's quite unsatisfactory for patients. So we have many non-pharmacological options, as hydration, avoidance of triggers, stopping some suspected medications that might be causing the cramps, different protocols of regular muscle stretching. Then we have also some pharmacological medications that we can use. The two drugs with the best evidence are vitamin B complex and diltiazem. Both should be tried for at least 2 weeks and then evaluate their efficacy. Another quite effective therapy is quinine, which should, however, not be considered first-line choice due to the potentially severe side effects related to the use of quinine, especially cardiac arrhythmia, allergic reaction, and hemolytic uremic anemia. We have many supplements that can be also effective, at least in some patients, as for example magnesium, pickle juice, so different drinks with acetic acid, and then we have also the several drugs working as nerve membrane stabilizers, as pregabalin, gabapentin. And there is also a quite effective clinical trials proving the efficacy of mexiletine to relieve cramps in ALS patients. Overall, the evidence-based data for specific suggestions on the best treatment for cramps are quite scarce. we have some recent Cochrane reviews which identified the potential efficacy of specific stretching protocols, at least in reducing the severity of the cramps, if not the frequency. There are, as we all know, some doubts in the efficacy of magnesium, and last evidence-based review of symptomatic treatment of cramps is quite old, dating back to 2010, and highlighting again the scarcity of clinical trials with this indication. Often associated to cramps are fasciculation. We all know fasciculation is this muscle twitching, repeating sporadically and in a migratory fashion within a muscle belly. This is a patient with ALS. And we see in EMG the typical fasciculation potentials as spontaneous, random, and irregular firing discharges of individual motor units with variable waveform morphology and a typical popping corn sound. So let's see if you can hear the fasciculation in this EMG. You see the changing morphology. You see the high amplitude, high duration of these symptomatic fasciculations. Another good method to assess the presence of fasciculation is muscle ultrasound, and I warmly suggest you to listen to this presentation by Nens van Halfen, which is available on the EAN website, teaching the main indications of muscle ultrasound for the detection of fasciculations. And you see here these twitches. As in cramps, it is still debated the origin of fasciculation. As regards ALS, probably in the earlier stages of the disease, we have a central origin, meaning in the cell body of the lower motor neuron. As the denervation progresses, and we have more distal origin within the motor nerve axon and the more distal terminals with nodal hyperexcitability. We can distinguish benign and symptomatic fasciculation. Many of us have fasciculation after exercise, mainly involving the calf muscle or lower limb muscles. Benign fasciculations can also be seen in cramps fasciculation syndrome and can be associated to anxiety. And then we have many causes of symptomatic fasciculations. They can be observed in motor neuron diseases. This is a patient with Kennedy disease with typical perioral fasciculation, especially observed when he starts to speak. And then here on the right side, we see a patient with tongue fasciculations typically observed in ALS, but we can also have fasciculation in other peripheral nerve hyperexcitability syndrome, in multifocal motor neuropathy, plexopathy, radiculopathies. So are we able to distinguish benign from symptomatic fasciculation? We can have some features some clinical features, some EMG features, and some ultrasound features that can help us in the differentiation. Mostly the fasciculations seen in ALS are more frequent. They involve mostly proximal limb muscles rather than distal limb muscles, more commonly involved in non-ALS patients. The detection of fasciculation in the bulbar and truncal muscles is highly indicative of ALS. And also the morphology of fasciculation help us, as we usually see in neurogenic fasciculations, higher amplitudes, longer durations, and complex morphology with many turns or faces. Often associated to fasciculation are also myokemia, which is continuous undulating muscle movement, like a continuous fasciculation, which appears like a worm between the skin. We all have experienced now and then the typical eyelid myokemia, caused, for example, by sleep deprivation. And we have in EMG the typical counterpart of myokemic discharges, which are characterized by 3 to 6 bursts of spontaneous firing of single motor unit potential at a uniform rate, which occur quite repetitively and give these sounds like marching soldiers that we might see in this video, where the patient has here another form of focal myokemia after radiation involving the right side of the tongue. And on EMG, you can hear the typical sound of these marching soldiers. In addition to focal myokemia, which may often involve facial muscles, we also have generalized myokemia, as we see in this young patient complaining in the last 5 years of continuous muscle twitching. Furthermore, excessive hyperhidrosis and some gastrointestinal complaints as diarrhea. So we see here the continuous muscle twitching of the calves, here in the thigh, and even in the small foot muscles, with these worm-like movements under the skin associated to this calf hypertrophy. In EMG, we see these myokemic discharges and fasciculation, but we haven't seen neuromyotonic discharges or triplets. And the laboratory tests showed slightly positive Caspr-2 antibodies, which confirmed the suspect of peripheral nerve hyperexcitability, and the patient responded very well to immune therapies. So we have basically 3 forms, 3 syndromes under the name of peripheral nerve hyperexcitability. They represent a clinical spectrum. On the mildest end of the spectrum, we have the crampy fasciculation syndrome, when patients usually also have prominent autonomic symptoms. We have the Isaacs syndrome. If they have also prominent involvement of the central nervous system. We have the Morvan syndrome, which also overlaps with limbic encephalitis. And as we move from the mildest to the more severe end of the spectrum, the probability of detecting the specific potassium channel complex antibodies increases. And usually we see more often transport-2 antibodies than LGE. These can be paraneoplastic or associated to other autoimmune diseases. And in addition to the myochemic and fasciculation discharges, we can also see the typical neuromyotonic discharges, which are detected not very often. They might resemble in their sound and shape a myotonic discharge. However, differently from the myotonic discharge, the firing rate is much higher, higher than 150 to 100 Hertz, and it has a typical pinging sound. Acquired peripheral nerve hyperexcitability are treatable. We can start with a symptomatic treatment if we have very mild symptoms, so we can try immunosuppressive treatment. Steroids is what our young patient got. In some refractory cases, you can also try rituximab. We should also think of some hereditary form of peripheral nerve hyperexcitability, as we might see in episodic ataxia type 1, where we have the combination of episodic ataxia and myochemia, especially in the facial muscles. We can also have myochemia in some neonatal onset epileptic phenotypes, also associated to this specific isoform of the centrally expressed potassium channel. And another form of hereditary peripheral nerve hyperexcitability is this hint1 hereditary polyneuropathy, characterized by severe and usually early beginning axonal polyneuropathy with EMG detection of neuromyotonic discharges. Under the group of hereditary peripheral nerve hyperexcitability, we should also consider this very rare syndrome, the Schwarz-Jampel syndrome, which is caused by mutation in the Perlecan gene, and it was quite surprising that this mutation was responsible for these myotonic and neuromyotonic discharges, as Perlecan is basically involved in the basal membrane. So there are two main hypotheses for the role of Perlecan in this hyperexcitability. Perlecan is involved in clustering of acetylcholine esterase, so that a deficit will lead to less acetylcholine esterase activity, and therefore more acetylcholine in the synaptic cleft, or a role also in the interaction with sodium and chloride channel, and therefore an altered function of these channels. We have some very typical clinical features with these prominent generalized muscle hypertrophy, with muscle stiffness, with blepharophimosis, so this inability to completely open the eyes, and some osteoarticular deformities as bowing of long bones, hyperlordosis, and pectus excavatum, for example. In EMG, we see a combination of myotonic and neuromyotonic discharges. Last but not least, for the sake of completion, we should also think of tetany. not as rare as the previously discussed syndromes, associated to reduced levels of plasma calcium, which increases the permeability of the sodium channel, and thus favoring depolarization of the nerve membrane, with hyperexcitability at the peripheral and central nervous system. And we have the two typical clinical signs of latent hypocalcemia: the Trousseau sign that we observe after ischemia with the typical obstetric hand, and the Chvostek sign that we see after tapping, when tapping the facial nerve, that we observe the typical twitching of the innervated muscles. And on EMG, for example, this EMG is performed under Trousseau sign. We typically see these duplets or triplets or multiplets typical of hypocalcemia. So to summarize, neuromuscular hyperexcitability syndromes are many, and there are many different diagnoses that might be associated to these clinical features. The combination of medical history, clinical examination, and EMG usually allow a proper characterization of the features and then a proper diagnosis. To do so, we need to extend a bit our standard neurological examination, looking for further signs, for example, for myotonia, for rippling muscle disease, for warm-up phenomenon, for fasciculations. And it is important that we properly characterize these features, because many of them are, if not curable, at least treatable. And then it's very important that we are able to properly counsel patients and reassure them about the prognosis, or identify those diseases with prognosis. So thank you for your attention. I hope that this presentation was helpful in the clinical differentiation of these syndromes, and I'm happy to take questions or discuss the topic.
Thank you, Federica. Rather pleasant, extensive, and exhaustive presentation. I'm sure that can be revisited to enhance and in-depth look at many other aspects. There are no questions in the question
chat.
And we are a bit late, so I would propose that we finish by then. And I would like to thank you very much for your very nice and instructive presentation, and everybody for attending. This webinar will be available as a recording in our website in a few days. Thank you, Federica, and hope to see you very soon. Bye-bye.
Thank you very much. Bye. Have a nice day.